Kenrick Duru. I think I know folks here, but the co-lead of the RICMAR. And we're very excited to have one of our newest GIM HSR faculty members joining us, Dr. Melissa Way. She's an assistant professor and completed a dual MD MPH in medicine, epi and stats at OHSU, then trained at Emory and did a fellowship in general medicine at Harvard, and also got a master's there in nutritional epidemiology. And her research focuses on the measurement, management, prevention, and policy implication of multimorbidity. And one of her goals is to identify risk factors for multimorbidity in order to implement interventions to prevent its progression and complications. Dr. Way, welcome, and please start when you're ready.
Thanks so much, Dr. Drew.
I believe you may need to switch the displays, Dr. Way.
Okay, are you seeing, what are you guys seeing? Because I'm seeing my presentation mode.
We're seeing sort of the presenter view.
Oh no, okay.
Okay.
Gosh, I wonder, so it won't let me not do.
Oh.
Okay, is that better?
If you go back to the presenter view at the top, I think if you hit swap.
Yeah, how do I?
Right
okay. There. Okay, perfect.
Perfect, looks good.
Great, thanks so much for that. I always wonder what it looks like on the other side. Okay, so thank you everyone for inviting me to present on multimorbidity. So today I'll be talking about measuring multimorbidity in health services research. I have no conflicts of interest and I acknowledge my funding. So I have 4 primary objectives for today. So the first is to introduce the construct of multimorbidity, and I'll illustrate this with a case Mrs. Smith, who is one of my patients in residency clinic. I'll define multimorbidity and I'll briefly describe some of the predictors. I'll then move on to how we can measure multimorbidity, and I will also discuss some considerations in diverse populations. Finally, I will discuss some of the prognostic outcomes of individuals with multimorbidity. So to begin, I'd like to discuss one of my patients in residency clinic. So Mrs. Smith was a 66-year-old woman, and she came in with multiple chronic conditions, but her chief complaint was always bilateral knee pain, and this severely limited her ability to walk, including going to the grocery store. And this was one of her greatest issues when I met her as an intern. So she's on a few medications for 4 primary chronic conditions. So she has hypertension, hyperlipidemia, diabetes, chronic kidney disease. And she is married, she lives at home with her husband, retired, has a very supportive family, and she has Medicare. So for today's assessment, I diagnose her with osteoarthritis, and the plan is physical therapy and acetaminophen as needed. But over time, when I first met her as an intern, she had the 4 chronic conditions, so hypertension, hyperlipidemia, chronic kidney disease, diabetes. I add osteoarthritis to her problem list. But the following year, she has hematuria in clinic, and this is diagnosed as bladder cancer. And the following year, she has an acute myocardial infarction, and this is complicated by heart failure. So in the span of these years, she has developed a new diagnosis of osteoarthritis, bladder cancer, and acute myocardial infarction complicated by heart failure. And by my senior year of residency, I noticed that she's also feeling depressed and has some trouble sleeping. So in terms of understanding her conditions and treatment burden over time, intern year, I added more conditions as I got to know her through residency. She also had more providers, so she was seeing urology, she was seeing heart failure and cardiology, and as well as physical therapy. She was adding more medications with each of the conditions that she acquired over time. And her healthcare utilization also increased, so office visits, imaging, labs, physical therapy, other types of modalities. And finally, her cost of healthcare utilization also increased with time. So there are many challenges of caring for patients with multiple chronic conditions such as Mrs. Smith. So first is that there are inadequate guidelines. So treatments are often targeted to single index diseases, and they don't necessarily account for people with many conditions at the same time. Older adults and sicker adults also tend to be excluded from randomized controlled trials. And this limits the applicability of many of our interventions on this sicker and older multi-morbid population. And finally, patients are complex and they each have their own combinations of conditions and they impact each of the individuals differently. The second challenge is with patient management. So we often want to do shared decision making that's person-centered, but this can also be very time-consuming in an office visit. There are also competing priorities. So patients may have more acute conditions. They may be hospitalized, such as in the case of Mrs. Smith. And we also have to account for preventive care, social needs, and this all needs to happen in a typical 20-minute office visit. We also have a very fragmented healthcare system. So this is very complicated with different care coordination among the multiple providers that patients have for all of their conditions. There are also safety issues, care transitions in and out of the hospital, as well as polypharmacy and the deprescribing that we should be doing over time. So what is multimorbidity? The clinical definition is the presence of several coexisting conditions in a given individual. These conditions may or may not be related to each other. And there isn't a single index disease designated as a single disease with comorbidities. And also these conditions endure and they accumulate over a lifespan, which is different from some of the acute conditions. In terms of operationalizing multimorbidity, there are more nuances in terms of the number of conditions that we include, what types of conditions we should include, and there are 100+ definitions and ways that people have attempted to try to quantify and define multimorbidity. So how does it differ from the common term comorbidity? So in comorbidity, there's an index disease, such as in Mrs. Smith's case, you could say it was her bladder cancer or her heart failure or her heart disease or osteoarthritis. So depending on the specialist, they each focus on a particular disease. And then all the other conditions that are not that disease are the comorbidities. But in multimorbidity, it's all of the conditions simultaneously, and there isn't necessarily an index disease. And this is often a construct that primary care providers will use, such as myself and all of you in the division, where we don't necessarily focus on one individual, but how all of these conditions interact with each other and how they impact that individual. So in terms of some of the risk factors for multimorbidity, the primary one is increasing age over time. So this is a figure from Scotland where they have the entire population from birth to death. And as you can see, there's a increasing prevalence of multimorbidity, which they use by the number of diseases as age increases along the x-axis. Lifestyle risk factors are also common for multimorbidity. So the individual risk factors for individual chronic diseases also happen to be common risk factors for that of multimorbidity. So in terms of the population attributable fractions, these include obesity, current smoking, and former smoking, and this is using data from NHANES. In terms of the policy relevance, one of them is that there's increased healthcare utilization and increased healthcare spending as the number of chronic conditions increases. So I would next like to transition to how to measure multimorbidity. So primary multimorbidity measures have had a few limitations. So these include the selection of the conditions to be included in the definition. How do we deal with the severity of the disease? Is that even possible to measure and include in a definition? And then finally, what is the setting? Is it outpatient? Is it inpatient? Are these individuals coming from the community dwelling population, or are they hospitalized individuals? What's the type of data? Is it EHR data? And one of the common historic ways we've decided how sick a person is by clinical gestalt, or the end of bedogram. So I can see a patient in clinic or hospital, and I can kind of tell, like, this person's not doing well, this person's really sick. I would just call this person less sick or more sick. It's kind of hard to quantify. It depends on the individual and their experience. So expanding beyond clinical gestalt, people have said we should count the diseases. So they have hypertension, they have diabetes, they have hyperlipidemia, they have 3 for their multimorbidity. And Elixhauser comorbidity is one of these measures, and it essentially counts conditions, and they are not weighted, and this is in an inpatient setting. Next, some of the indices have said we shouldn't count diseases, we should actually weight them by how they impact an individual. So the Charlson Comorbidity Index did this, and it weights the conditions by the impact on future mortality. So they say, like, a condition that's more likely to kill you, that should count more than a condition that's less likely to kill you. However, I would argue that we need a modern and universally applicable measure for multimorbidity, not just in the inpatient setting, but also in the community. And then we should assess the validity in multiple different types of data sets. So I've been working on a multimorbidity weighted index that I will describe in the upcoming slides. And I've been trying to make this available as a way to capture multimorbidity among community dwelling adults. And then I've also looked at ICD coded versions, so we can apply this index using administrative claims data as well as electronic health record data. So just to illustrate the different types of ways to measure multimorbidity, so in our patient, Mrs. Smith, if we were to simply count the diseases, she had 4 by intern year, and then by the time I graduated from residency, she had 8 conditions. The most cited index, and one of the most popular ways for measuring multimorbidity and comorbidity, is the Charlson Comorbidity Index. This was started with 19 diseases. It was a small inpatient sample in New York City in 1984. And this is how the index works. So these are the conditions that are weighted 1 point. And then there are other conditions that are more likely to increase risk of mortality. So these diseases are ranked 2 points, 3 points, and up to 6 points for metastatic solid tumors and AIDS. So if we were to use the Charlson Index for Mrs. Smith, what would that look like? So for the Charlson Index, intern year, she would have 1 point. And the reason why it's lower than count is because some of the conditions that she had were not associated directly with mortality. So for example, osteoarthritis would not count. There are no Charlson points for that because of the lack of association directly with mortality. And then by the end of my senior year residency, she would have had a Charlson score of 5. So as you can see with Charlson, it tends to underestimate multimorbidity based on conditions that affect individuals in the outpatient setting. So osteoarthritis, depression, insomnia, those don't get any points with the Charlson Index. So if you ask people in the community what matters to them, so mortality is one of the important outcomes, but that's not always the most important outcome for individuals who are surviving with their chronic conditions. So oftentimes when you ask patients in clinic, like, what matters to them, and the patient priorities care movement has similarly been seeking this question, oftentimes it's being able to function, being able to do activities, engage in hobbies, go outside, spend time with family. And those are some of the outcomes that are important for individuals who are surviving with their conditions, in addition to not wanting to die from their conditions. So in terms of all of the different ways to weight conditions, I would argue that physical functioning is one of the most important ones. And there are a few reasons for this. So we know that as age increases, as well as the disease burden increases, physical functioning tends to decline over time. But the nice thing about physical functioning is that there are areas where we can intervene and potentially intervene earlier. So before someone is completely disabled, are there times where we can say, okay, this person is about to become disabled, or this person is on a trajectory to become disabled? Can we target them individually at earlier states? And physical functioning is also a very important universally valued outcome for all people. So I've been focused on weighting conditions by physical functioning. And so some of my early work was to say these are a lot of the conditions that impact individuals in the community. How do those conditions impact their physical functioning? I then assessed the validity of this index by testing the index for different outcomes in the health and retirement study, which is nationally representative. So I'll next describe some of these measures. So the multimorbidity weighted index, or the MWI, weights diseases based on their impact on the SF-36, the short form 36 physical functioning scale. So this is a 10-item scale. And the nice thing about it is that it ranges widely from vigorous activities, running, lifting weights, doing strenuous sports, things that people of all ages can enjoy, as well as the more simple tasks, not necessarily simple, but more age limiting tasks such as bathing, dressing, more activities of daily living. So there's individuals from all the way from the youngest of young to the oldest of old can have some degree of measurable physical functioning using the short form 36 scale. The items are a 3 response category, so they are either not limited at all by these individual activities, they may be limited a little bit, or they may be limited a lot. And then this physical functioning scale is then the average of the 10 items. So for the analysis, I did a longitudinal analysis looking at the impact of individual conditions and the regression coefficient on physical functioning. I had over 700,000 observations from 216,000 community dwelling adults from 3 large cohorts spanning 1989 to 2016. These individuals had repeated measures of diseases every 2 years and physical functioning from the SF-36 every 4 years. So I used mixed effects models that could account for missingness in the data. I also assessed for effect modification by age and sex, and there were not significant differences throughout all of the conditions. So I ended up doing a meta-analysis to combine the regression coefficients that I acquired from each of the 3 cohorts. So I initially considered 374 conditions. The multimorbidity index includes 81, and there are 74 of these conditions that are weighted based on their impact on physical functioning. To assess the validity of the index, I did bootstrapping and cross-validation for internal validation. So one of the convenient aspects of the multimorbidity index is that it has a clinically meaningful interpretation. So if I say, what is this person's multimorbidity weighted index? It represents both the disease burden, so their cumulative multimorbidity, but because the conditions are weighted by physical functioning, it is also an indirect way of summarizing someone's physical functioning, but without needing the SF-36 calculation. And conveniently, it calibrated so that one increased point in multimorbidity was associated with a 1-point decline in the short form 36 physical functioning. So in other words, the multimorbidity disease units are approximately the same as multimorbidity physical functioning units from the SF-36. So each point in multimorbidity is also 1-point decline in the short form 36 physical functioning. So just to help illustrate the impact of some of the conditions, these are the top prevalent conditions in the 3 large cohorts, the Nurses Health Study 2, and the Health Professionals Follow-Up Study. And it ends up that these diseases are also those most common in the general US population. So elevated cholesterol, high blood pressure, osteoarthritis, benign breast disease. This histogram shows that even among these really common conditions, there's also a wide-ranging impact that these conditions have on an individual. So for example, osteoarthritis was associated with a 3-point decrease in physical functioning compared with cholesterol, which was basically nothing. And that could also be from medication side effects, for example. So in the patient, Mrs. Smith, these are the conditions that she had. So cholesterol, blood pressure, osteoarthritis, depression, diabetes, many of the common conditions. But then what about some of the most impactful conditions? So these are the worst conditions in terms of their impact on physical functioning. And I would say that there's fairly good face validity in terms of what I would consider to be bad or more debilitating conditions, where the general pattern was the more chronic progressive neurologic conditions like multiple sclerosis, Parkinson's disease, ALS, dementia, those scored very high. And in the SF-36, 10 points is one standard deviation. So an individual with multiple sclerosis had an entire standard deviation worse physical functioning compared with a person without multiple sclerosis. The next pattern was that it tended to be end stage organ conditions like lung cancer, dementia, congestive heart failure, COPD, chronic kidney disease, rheumatoid arthritis. These are very debilitating conditions at the end. In our patient, she had two of these very debilitating conditions, CHF and CKD. So in terms of how to measure multimorbidity using the multimorbidity weighted index, where the conditions are then weighted by their impact on physical functioning. At intern year, Mrs. Smith would have had a multimorbidity weighted index of 9.4. And then by my senior year residency, this had increased to 21.3. So it was the count of the diseases, but then multiplying the count of each disease by the impact on physical functioning. So to make this readily available for providers, patients, researchers, I fortunately was able to include the multimorbidity weighted index on the ePrognosis website. So you can automatically calculate the index for individuals, and it will output the multimorbidity weighted index, as well as the 10-year mortality risk and 4 to 8 year decline in physical functioning. To make this multimorbidity weighted index applicable for some of the common data sets we use in health services research, so claims data, Medicare, electronic health record data increasingly now, I worked on coming up with a way to ICD code the multimorbidity weighted index. And I wanted to see whether the ICD codes versus self-reported conditions would differ in their impact on physical functioning. So here I use data from the health and retirement study, so nationally representative adults, and these individuals consented to have their HRS data linked to Medicare. And so here I had over 73,000 observations of data from 18,000 adults spanning over a decade. So the goal was to expand the multimorbidity weighted index. If I look at ICD codes, what would be the impact with physical functioning? So here there were over 14,000 ICD-9 codes represented, with over 3,000 procedure codes represented. And I ended up grouping all of these into 69 disease groups representing over 2,000 ICD-9 codes. I again used mixed effects models, and I had to account for collinearity and confounding, which is why I combined a lot of the disease groups. And for internal validation, I assessed this through bootstrapping. And ultimately, I found that the self-reported multimorbidity had better face validity compared with the ICD-coded version, likely due to the nature of the data and some of the biases that can result with ICD-coded data. So instead of using the ICD-coded weights, I took the original conditions for the multimorbidity index from self-report, and then I mapped them to ICD-9 codes. And then with the ICD-10 transition, I then mapped them to ICD-10 codes. So I have these available in SAS and Stata macros that will take a condition or ICD-9 or ICD-10 code, and it will output the multimorbidity weighted index. So to give a sense of how the multimorbidity index compares with some of the other measures, one of the greatest strengths is that it has a broad distribution to describe multimorbidity at both the low ends as well as the high ends of multimorbidity. So in red, we have the multimorbidity index where about 7.5% or so of individuals have a score of 0, but then this increases far, far out to like 54 or so, and the mean was around 9. In green, we have disease count. So if we just counted each of the diseases, there's about 5% or so with a score of 0, and then there's a normal-ish looking curve, and then it peters out around 16, 17. With the traditional indices that we've been using for comorbidity, such as Charlson and Elixhauser, one of the common themes is that there tends to be more left censoring, where a lot of individuals will have a score of 0 because the conditions they have don't directly associate with healthcare utilization or mortality. So they're not counted in these indices. So individuals tend to have more zeros when you use Charlson or Elixhauser, and then there's a limit to the number of conditions that they can have. So if a person has all of the 19 Charlson conditions or all of the 19 Elixhauser conditions, there's a ceiling effect where they can't really have a higher score. So another way to look at this is to consider the number of potential unique values to quantify a person's multimorbidity. So in this data set with Medicare HRS, there were over 5,000 potential values that these individuals had for multimorbidity, whereas with Charlson and Elixhauser, there were only 19 unique values from the integers that they could be added. So one of the gaps in measuring multimorbidity is assessing for disease interaction. So far, all of these conditions, they just assume that diseases are additive, but what about diseases that are interacting with each other in complex ways? Is there something that we should account for in terms of how this would impact their other outcomes like physical functioning? So in order to assess this, I wanted to look at higher order disease interactions. So 2 diseases interacting, 3 diseases interacting, and even higher orders like 4 diseases, 5 diseases. Do those diseases interact with each other in meaningful ways that we should actually be capturing when we measure multimorbidity? Or is it safe to say we can just add them and then just be done with it at the end of the day? So to tackle this problem, I've been examining different shrinkage methods like lasso and elastic net. I also tried using random forest, and I took a class on machine learning in R over the summer, and there's this RFSA package that I also tried. And then ultimately, I ended up using a more curated form of the top most prevalent and the top most impactful conditions because it was very computationally difficult to look at all 81 conditions and all of their potential interactions. It basically just shut down the program multiple times. So it's a challenging computational problem that also is difficult on SAS or Stata or R. But ultimately, using the lasso, the inclusion of the disease interactions did not improve the model fit. And there was just like the parsimony was much worse. And at the end of the day, I would conclude that it's okay to add the conditions. There isn't much gained when you have the hypertension plus diabetes plus the interaction of those 2 conditions, at least in this data set, HRS Medicare data, weighting the diseases to physical functioning. So to summarize some of the measures of including the multimorbidity weighted index with traditional measures, the multimorbidity weighted index had the broadest distribution to quantify multimorbidity. It had the most unique values in the HRS Medicare data, as well as the least left censoring. Had a greatest contrast across quartiles, which I will show in the upcoming slides for some of the outcomes in terms of the R squared and outcomes such as physical functioning and 10-year mortality. So the different ways to measure multimorbidity have been very challenging. And the NIH actually convened a workshop in 2019 where several multimorbidity researchers gathered and said, like, how should we measure multimorbidity? And ultimately, the conclusion was that it depends on the purpose of the research question, as well as the types of data sources that an individual has. So we compiled a lot of the current instruments and then kind of matched it to whether you have claims data, EHR data, prospective cohort data, population-based surveys, and then also, what is the purpose? Are you interested in assessing for readmissions or mortality? This table is really small, but this paper recently came out in Medical Care and includes a full table of examples where different data sets can be matched and different instruments can be matched based on your question as well as data set. So I would now like to shift to some of the considerations for measuring multimorbidity in diverse and vulnerable populations. So one of the goals is to understand multimorbidity, including unique phenotypes, the history of the progression, what is the onset, what is the progression of multimorbidity, and what are some of the consequences of multimorbidity. The goal would be then to target interventions to prevent the onset, progression, and complications of multimorbidity at an earlier state. So what are some of the things that we need to know in different populations in order to do this? One of the experts in the field of studying multimorbidity in multimorbidity and disparities is Anna Quinones. And so she has done a lot of work in the health and retirement study looking at different trajectories of non-Hispanic Blacks, non-Hispanic whites, as well as Hispanic individuals, and then tracking their multimorbidity onset and progression over time. And she found that non-Hispanic Blacks that you can see here in the red line, they have an earlier onset of higher multimorbidity, and they have, everyone has like a very rapid increase with age. So by the time people are in their 60s and 70s, most people have acquired many conditions, but depending on race, ethnicity, the trajectories will differ. This is just one of the papers from her work where she's done just like a whole literature on trajectories and trends in different populations. Another vulnerable group is those with lower SES. So this is, again, data from the Scotland group, and they have the entire population from birth to death. And you can see here in red, these are the individuals who had the who were most deprived from socioeconomic status. And then those in black are the most affluent individuals in this population. So even as multimorbidity increases with age in this population, you can see that there's a difference where those who are most deprived had a higher worse multimorbidity compared with those in the most affluent group. Another vulnerable population is homeless adults, and Australia has done really great work in this area, and they have these mainstream clinics versus street clinics, which targets homeless individuals. And here they also show that the rates and trajectories that people get multimorbidity differ. Homeless individuals are not often seen in mainstream clinic and to get those official diagnoses, but they too also acquire many conditions, and they tend to do so at an earlier onset of age compared with those in the general population. In terms of other vulnerable groups, those with autoimmune conditions, such as rheumatoid arthritis, are also a group at risk for higher multimorbidity. This is a longitudinal study using the Nurses Health Study. And here we looked at multimorbidity and excess mortality. So on the top, these are individuals with rheumatoid arthritis. And then on the bottom are group to compare. So these were matched individuals. And this essentially shows that individuals with rheumatoid arthritis had much higher multimorbidity, and that they had higher multimorbidity that was associated with excess mortality that was due to their multimorbidity. So finally, I would like to describe the prognosis of some of the prognostic outcomes of individuals with multimorbidity and what we can do about it. So going back to our patient, Mrs. Smith, this is a conceptual framework that I've used to guide some of the studies on multimorbidity. So I started out wanting to know what are some of the causes, what are the predictors of multimorbidity, whether it's age, sex, socioeconomic status, lifestyle, behavior changes, social supports. But then I got into the space, well, how do we measure multimorbidity? How do the diseases interact with each other? And is this something that we can capture in a better way? To assess multimorbidity, there are several downstream consequences. So how does multimorbidity impact an individual's functioning, whether it's physical functioning, cognitive function, socially function? And then how do these diseases and functioning impact disability measured by activities of daily living and instrumental activities of daily living? And then next, after that, how do these functional status and disability, how do those impact an individual's social participation in life and quality of life? And then ultimately, the outcome that is commonly assessed is mortality. So how does multimorbidity increase one's risk of mortality? But as you can see, there are several upstream consequences of multimorbidity, and I assessed each of these outcomes in my studies. So one of the most important outcomes is mortality. So here I examined multimorbidity. On the x-axis, I have increasing quartiles of multimorbidity and the hazard ratio of mortality. And here I examined in blue the multimorbidity weighted index that includes all of the original conditions, including those that are in the Charlson index. But in the red, I actually removed the Charlson conditions to say, okay, if I don't include Charlson conditions, of those that are remaining in the multimorbidity index, do those also predict mortality? And here you can see that multimorbidity with and without Charlson, those are both associated with increased risk of mortality after 10 years. In terms of other outcomes, I've looked at objective and subjective measures of physical functioning and cognitive functioning. These are just two examples in the health and retirement study. So grip strength, there's also gait speed, global cognition, and individual domains of cognition. I demonstrated that as multimorbidity increases, as measured in quartiles here, as well as a continuous measure, the general trend is a monotonic worsening of physical functioning, cognitive functioning, and each of the different domains of physical and cognitive functioning. I've also demonstrated that as multimorbidity increases, there's an association with worse ADL and IADL limitations. So as multimorbidity increases, the number of ADLs increases and the number of IADLs also increases using data from the health and retirement study. In terms of health-related quality of life, which is one of the most important outcomes for patients, here I have examined future physical health-related quality of life, as well as future mental health-related quality of life. And what's really interesting about the SF-36 is that the physical component summary and the mental component summary are actually orthogonal by design. So they're meant not to be associated with each other. But interestingly, physical functioning, as we would predict, is associated with the individual domains in the physical SF-36. So physical functioning, the role and impact that physical functioning has on an individual, pain, general health and vitality, even 8 years later. So that's not very surprising. But multimorbidity is also predictive of future mental health related quality of life in each of the different domains of mental health. So general health, vitality, social functioning, emotional health, and mental health. And so this is not as surprising from a clinical standpoint, that because we know that physical and mental conditions are intricately linked with each other. So in the future, there's this association with worse physical functioning, worse mental functioning. And perhaps one of the worst outcomes for mental health related quality of life is suicide mortality. So here I looked at 3 large cohorts, men, women, younger women, and demonstrated that as multimorbidity increases, the hazard ratio for mortality from suicide also increases over decades of data. So in terms of Mrs. Smith's long-term prognosis, I've looked at some individual factors, but what about healthcare system level factors? How does that impact some of these other outcomes? So in terms of 30-day readmissions, and which is an interesting outcome given the penalties, here I examined increasing multimorbidity weighted index on the x-axis and the odds ratio of a 30-day readmission. And there's essentially a monotonic association with increasing multimorbidity and an increasing odds of readmission. If looking at these data from a continuous standpoint with the HRS Medicare data, each point increase in multimorbidity was associated with a 2% higher odds of readmission over 30 days. A 2% higher odds of death following discharge within 1 year, and a 1% higher incidence of a longer hospital length of stay. So in summary, multimorbidity is associated with several bad outcomes. So multimorbidity tends to increase over time as individuals age, and it also predicts many poor clinical outcomes. So these include all-cause and suicide mortality, several objective and subjective measures of physical functioning, such as grip strength, gait speed, global cognition, each of the types of memory, immediate and delayed recall, ADL and IADL limitations, social participation, physical and mental health related quality of life using the SF-36, 30-day readmissions, and longer length of stay. So now we know that multimorbidity is really bad. What can we do about it? What are some of the research and policy applications? So from a research standpoint, there's a lot of interest in understanding multimorbidity phenotypes. What is the biology and pathophysiology behind individuals who tend to get not just one, but like many chronic conditions simultaneously? From there, what are some of the trajectories? How do these individuals progress over time? There are some individuals who tend to have a certain level of multimorbidity maintained, but then others who shoot up and require multiple conditions and fare far worse than their peers. And finally, from a policy standpoint, we often will risk adjust for comorbidity or multimorbidity. And how do we do this in a way that quantifies individuals in the whole distribution of multimorbidity? From a clinical standpoint, how can we improve patient care? So from the patient experience, individuals with multimorbidity have a very high treatment burden, whether through office visits, labs, imaging, multiple specialists, multiple medications. There's a lot that we can do to try to coordinate care better or batch medications. And then also to assess the patient preferences and goals of care, since we might not necessarily be able to do and maximize each individual index disease. But a movement led by Mary Tinetti has been eliciting individual patient preferences. And at least if we can't meet individual disease guidelines, at least we can do what that patient wishes. I think there are also opportunities for decision support. So there are a lot of interventions that we do on patients, and we don't necessarily know the outcomes based on where they started out at baseline. So for example, preventive services, we often will cut off the preventive services based on age, a chronologic age, but what if we used a biologic or a functional age? If there's a 50-year-old who has several chronic conditions and is functionally like a 70-year-old in terms of prognosis, do we still need to aggressively screen for cancers? In terms of surgical candidacy, there are things that we do for pre-op optimization, and it includes a handful of conditions, but what is the general picture of the patient? What is the general picture of their physical functioning? And are there ways that we can predict who will do well with an aggressive operation versus who will actually not ever return to baseline, so maybe it's not worth it in the end. In terms of advanced directives, this is also something that we tend to do, with Medicare wellness exams. And again, it's targeted based on age and chronologic age, but maybe we should be initiating some of these conversations earlier among younger patients who are functionally older than their age suggests. And finally, in terms of discharge planning, sometimes when patients are hospitalized, we don't really know what their baseline functioning was. And, how do we decide whether they should go to a skilled nursing facility or home with healthcare? Multimorbidity and function is a potential way to try to gauge what their needs will be after they're hospitalized and their function is even worse than their baseline. So in terms of decision support, this is something that some electronic health records already do. You may have heard of the LACE score. And the C in here is the Charlson Index. So they've incorporated the Charlson comorbidities into discharge planning. So this is some decision support that is already done in some hospitals. Finally, in terms of population management, what are some of the things that we can do to identify patients who are high cost and high need? And are there better ways that we can allocate precious resources? One example is complex care management. So it's amazing for the people who have complex care management, but it is a limited resource. Not everyone can have, a nurse care navigator. But then how do we determine who should get complex care management? Is it the person who has many ED visits or many hospitalizations, or are there ways that we can kind of look at the whole picture of our patient population and say, this is the sickest individual, this is the less sick individual. There's a gray area in the middle. Maybe some of these patients would or would not benefit from complex care management. And then finally, something that I've been really interested in is looking at what we do in the office visit as primary care providers. Are there ways we can identify who needs to be seen more often and in what frequency, who can benefit from a telephone call versus who needs an in-person visit? COVID has particularly changed that and kind of just thrown us all in there in terms of trying to figure out needs who needs to be seen in what modality. So going back to my patient from intern year, so Mrs. Smith, so she came in with many chronic conditions, but her chief complaint was always the bilateral knee pain and osteoarthritis. And she's had a really profound impact on me and my research interests and going into what I now describe as multimorbidity and how we can better take care of patients like her, how we can prevent the onset and progression, and even simple things like how often should we decide when to see her back. And so in my visit, I tended to see her back every month because she had many chronic conditions that were not quite tucked in for the moment. But is there a better way to quantify and decide how to do this? So thank you very much for your time. I'm happy to take questions.
That was terrific. Thank you, Melissa. So I think, yeah, we're open. I have some, but I'll let others go first if you have questions to ask.
Thank you very much, Dr. Duru. If I can interrupt for 1 second, I just sent out in the chat our survey evaluation for this talk, and I can also post a QR code if that's okay. Dr. Wei, for a few seconds so that people can scan it and get it done really quickly. And if you need to come back to the slides, please let me know. We can put those right back up.
I had a question, Kenrick.
Go for it.
I'm not sure, it's a little hard to ask, but you went through a lot of material, so it was great, like Kenrick said, and I should remember some more because I saw the JGEM paper you submitted, but my memory's not great. It sounded to me though, like when you were describing in the beginning what you did, that you're talking about things that accumulate, and then I was getting a little concerned or not sure I was understanding, and it didn't sound like there were a lot of like mental health conditions included. So I just wanted to get a little, first of all, a little clarity on what you decide to include as in your condition list. And, you know, does it have to be something that stays with them, like a chronic condition, and can mental health be included? Because then you showed us those results at the end related to, you know, SF-36 mental health.
Yeah, thanks, Ron. That's a great question. So when I conceptualized multimorbidity, I included physical and mental health conditions. And I wish I could include more, but oftentimes the limitation is the data and the quality of the data. So in the initial multimorbidity weighted index, I had depression, alcohol use, PTSD, but I didn't have all of the conditions that I wanted. So I did include all of the mental health conditions that I had available. But then with the next iteration with ICD-9 codes, ICD-10 codes, I said, okay, here's an opportunity to conclude all of those other conditions that I didn't have in the self-reported surveys. So I expanded those conditions to include anxiety and all of the conditions that I could assess and had adequate sample size. But then one of the challenges I had with the claims data, or that the data were really messy, and I don't know if it necessarily reflected an individual's chronic conditions due to all of the different coding. So I ended up imputing some of the conditions that I could. So for example, anxiety, I gave the same weight as depression. I don't have an exact way to quantify it, but I know that it impacts an individual. And the closest I could do was to estimate conditions within that same organ system group. So similarly, I had data on alcohol abuse. I looked at substance use disorders and each of the individual substance use disorders, but I didn't have enough data on each of the individual conditions to include. So I wish I could include them, but there's just not a lot of data. And I think that some of these conditions are not captured adequately in the claims data in ways that I wish. So in that case, I suggested including either the weight in that organ system or the generic weight, which is just all of the conditions on average. So we think that that condition impacts an individual, but we don't have an exact number to give it. And to your next point about chronic conditions, so multimorbidity, I think about as chronic conditions that tend to endure with individuals over time. And they can be relapsing and remitting, such as some of the mental health conditions we know, such as depression. Oftentimes there will be individual flares, or there's certain level of maintenance that people have over time to keep their condition maintained. And so I often would include I would carry forward conditions where I knew that there was a chronic impact, but for conditions where I couldn't necessarily state that, this person is having depression throughout this time, I would input the data in each of the years that I had available. So I wouldn't carry forward the condition with time. I wouldn't assume that the depression stayed with them for, each of the years. So there's a different way that I assessed conditions for mental health compared with physical conditions. So diabetes, that was definitely carried through. Even if a person's A1C improves with time, they're either taking medications, they've had to maintain lifestyle changes. This is all part of the burden of disease over time.
Okay, so that was a great answer, and I'm not going to take up any more time except to say I think it would be interesting, although you probably have burned yourself out because you've done so much, is rather than just predict physical function, to predict like the SF6D, which is more of a summary preference score that includes, mental health, or more better currently would be the PROMIS PROP-R, which is a equivalent or better preference measure. But I'm going to leave it at that. I know Kendrick has questions.
Well, it's actually a follow-up on yours, Ron. So I guess, Melissa, thank you for bringing that Medcare article to our attention. I'm going to pull it to look at kind of the results of that coming together to identify the best approaches. But in your mind, I guess, with your index, are there populations or data sources where we shouldn't use that, where there are other ones that might be a better fit? Kind of where are the situations that you would recommend using this versus going with something else?
Right. Do you have like a specific example, or just
Oh,
in
well, I guess,
general?
yeah, I should look at the article to see. But in general, we do a lot of work with claims and trying to adjust for multimorbidity, looking at
Mhm.
outcomes among, older adults or even sometimes middle-aged adults. So that kind of thing. And I'll tell you, I'm with the network. There's 6 centers in this Natural Experiments for Diabetes Network.
Mm.
And I'm just going to email, actually, we have Tanaz Moin is the co-lead of the metrics group.
Oh,
And
yeah,
their
yeah.
mission is to try to get, similar metrics across the 6 sites. And so this is one of the kind of issues they've been tackling is, how best to measure this so that the network results are all kind of, using the same framework. So that's the general sense. We're all using claims data. Well,
Got it.
some are EHR. So I guess it's a complicated question, but let me just rephrase. Are there certain groups that you would warn, don't, be careful using this measure in this group or this setting?
Yeah. So I think in terms of the common indices like Charlson and Elixhauser, I think those indices perform really well in the inpatient setting where you have really sick individuals. So by the time people have cancer and heart failure and diabetes and are about to die or be hospitalized, those indices capture those conditions pretty well. I think where the limitation would be is when the individuals are younger and healthier and they haven't quite acquired more end-stage diseases directly associated with mortality and readmissions, but they still have conditions that impact them in other ways, including higher risk of mortality, health-related quality of life. So if you have an older population, you're more likely to get some value for Elixhauser Charlson. If you have a younger population, I would argue that if you want to quantify their burden of disease, you should also include, like PMS and migraine and osteoarthritis and other conditions that are really debilitating at young and middle-aged, at the young and middle-aged groups, as well as older adults, but that don't really get, they're not appreciated in the indices that are directly associated with mortality. So in terms of distribution, if you want to describe like a wide range of individuals, I would hesitate to use some of the mortality weighted indices.
And I guess also I'll just follow up too with one more thing. So do you have SAS and Stata code that you could share to run this?
Yeah, so I have the SAS code in the JAGS 2020 paper. So yeah, all the ICD-9 codes, all the multimorbidity weighted index. And then the paper that I'm working on right now is ICD-9 codes and ICD-10 codes in SAS and Stata. And that is done, but it's not accepted and so it's not on PubMed.
Got it. Okay. Yeah, so great. We have 2 more minutes on my clock, but any other questions for Dr. Wei?
I don't know if anyone else does. I have one other one that may be for later because it's going to run out of time. But when you first introduced the physical function from SF36, you were describing the 0 to 100 scoring. But then when you showed some results, you talked about a standard deviation of 10 when you were talking about multiple sclerosis, I think. And so I don't know, that would mean it was a T-score. It was transformed to have a mean of 50 and standard deviation of 10. And I wasn't sure if that was a different, you did it differently in that paper or whatever, because I was trying to interpret the size of those differences. And if it was 0 to 100, the standard deviation is probably closer to 20 rather than 10. So you won't have time to do it. Maybe just look back later, but I kind of got,
Yeah.
you know, if we had time to interrupt you, I would have interrupted you then.
Okay. Yeah, I'll check back on. I think I was
Very
using the
likely-
standardized normative.
Yeah, okay.
All right. I think, yeah, thank you so much for coming to speak to us. We really appreciated it. And, hope to see you in person as we all get back to the office.
I know, I can't wait to meet all of you in person.
All right.
All
Sounds
right.
good.
Thank you so much.
Take care.
Bye.
Thanks, everyone. Remember to register for our scientific retreat, June 21st and 28th.
Oh, yeah.
All right, everyone. Take care.
Okay. Bye.
Bye.